Friends, Pradeep Pindiala, your buddy and the professor of Anaesthesiology. Friends, since I have been giving lectures to my postgraduate students on a daily basis, I thought why I should not make short videos of snippets with important points, especially for the exam going students of MD or DNB or Diploma of Anaesthesiology, and also which could be useful for private practitioners of anesthesiology who would like to catch up with the latest developments on the go. And I'll be making videos in such format that you don't have to watch the videos. You can listen to it like a podcast. So yesterday I had given a lecture on post-Caesarean analgesia. So there have been growing interest in the use of analgesic drugs in the post-operative care, and you would love to know what are the things which are to be thought of. So what are the things? You can think of TAP block. Let's talk about it later. What are the other things? Ilioinguinal nerve block or iliohypogastric nerve block. And you can give high concentration, low volume of ropivacaine, either 0.5%, or you can give even ketamine. Okay. On COX-2 inhibitors like celecoxib for post-operative analgesia. Gabapentin can also be thought of. So we'll talk about it. So let me talk about the role of opioids, transversus abdominis plain block, that is TAP block, wound infiltration or infusion, ketamine, gabapentin, and as I said, ilioinguinal and iliohypogastric nerve block. Talking about gabapentin. Have you heard of gabapentin? I'm sure you know about it. You should know that it is actually was introduced as an anticonvulsant drug with significant analgesic properties. It binds to presynaptic voltage-gated calcium channels in the dorsal root ganglia of the spinal cord, which prevents the release of neurotransmitter. This you should be able to tell in the examination if somebody asks you. Okay? And what are these COX-2 inhibitors? Celecoxib, paracoxib, that provide safe profile for both surgical patients as well as post-Caesarean. Okay, what is ketamine? I'm sure you must have used it in a million times. Ketamine is a non-competitive antagonist. Always use the phrase non-competitive antagonist of the N-methyl D-aspartate receptor, NMDA. Okay. Entire anesthesiology revolves around two receptors, that is GABA and NMDA, with few exceptions. Okay, the ketamine is a non-competitive antagonist of the N-methyl D-aspartate receptor that inhibits central sensitization and has a preemptive analgesic role for post-operative pain relief after Caesarean section. We are talking about analgesia after Caesarean section. How to go about it? I did talk about high concentration, low volume administration of ropivacaine. You have to go for 0.5%, 50 ml. It's found to be very effective. Okay. And if you are using high volume, you can go for 0.2% of ropivacaine, which could be even up to 125 ml. Directly for the wound infiltrations. Okay. And talking about ilioinguinal and iliohypogastric nerve block, that I won't advise because further studies needs to be warranted before we start using ilioinguinal and iliohypogastric nerve blocks. Okay, now talking about TAP block, that's a part of multimodal analgesia after Caesarean section, which is definitely very useful in reducing opioid consumption and their side effects. I'm sure you know how to give about TAP block. Recently, there has been growing interest in the use of primary postoperative analgesic methods. The potential side effects could be great, and never forget oral oxycodone. Oral oxycodone is very, very useful, okay, and is preferred opioid for postoperative analgesia for Caesarean section. Patient control epidural analgesia. It is not patient control intravenous analgesia. Patient control epidural analgesia. You must speak few words about it. Satisfactory postoperative analgesia has been reported with Ropivacaine 0.025% to 0.15%. And if you are using levobupivacaine, use 0.15% levobupivacaine. And talking about lipophilic opioids such as fentanyl and sufentanil, if you are given it intrathecally, when compared to intrathecal morphine, they were found to be providing very good, but they usually give early post-operative pain relief. So always remember, the choice of drug can be intrathecal morphine. And for God's sake, don't give 2 to 3 milligram morphine intrathecally. Just give 30 microgram or 50 microgram or up to 100 microgram intrathecally morphine. That works wonderfully well. Okay, intrathecal and epidural opioid are very good. And traditionally, I'm sure you know, epidural morphine, when you are giving, you have to give 2 to 3 milligrams, not intrathecally. That is subarachnoid block, you don't give 2 to 3 milligram of morphine, patient would die. But definitely you can give epidural 2 to 3 milligram of morphine. Okay, now I'm sure you know you have been giving postoperative paracetamol, NSAIDs, and you can add, as I said, oral opioids such as oxycodone, postoperative analgesia for Caesarean section. Intraoperative interventions which could be considered, first is intrathecal, secondly it could be epidural morphine. TAP block can definitely thought of, and when you're talking of intrathecal morphine, go for 50 to 75 micrograms of morphine. Okay, so all the best. You can definitely try oral oxycodone as the post-operative analgesic. Thanks for patient listening. I'm sure you have enjoyed my brief talk and snippet for post-operative analgesia of Caesarean section. Thank you. I'm signing off for today. Bye-bye.